Often in general practice, whether you're in a practice, network or wider area, you get the opportunity to bid for resources in order to help your patients as well as your potential organisation, practice, etc. In this episode, you join myself and Andy as we're already partway through talking from a larger episode about the process we went through creating a clinical resource for our patients and what you have to consider when it comes to costing, organizational aspects, resources, guidance, all that kind of strategic stuff, and how you can use our free tool that you get access to at the end of this episode in order to do exactly that. Make your lives really easy, particularly as we go into bidding season right now. So let's join that episode right now.
Gandhi, do you want to have a go? We don't necessarily need to fill in the boxes live, but just to go through the thought processes. So I know you'd had an idea for a group video pain management project or clinic that you were going to do. So I'm going to let you can articulate rather than write your 100 words. We won't have the 1,000 words.
Okay.
But just fire away, just to illustrate some of the thinking around it, really, rather than needing to watch you fill all the boxes in, obviously.
Yeah. So benefit of using a tool like this, I guess, is obviously you can just copy over the template one that we've got there and name it, possibly put down the funding amount that you're looking at, because we've mentioned about having different levels of funding plans ready. So typically you may get pots of money that are, for example, under £1,000 or £2,000, £2,000 to £5,000, £5,000 to £15,000, and then you get into the bigger pots potentially, and for local projects, you're probably not looking more than maximum, I'd say £100,000, but you never know, on a network level that could be potentially larger and stuff. And then obviously on ICB or CCPA-based partnership level, you're obviously talking potentially much bigger pots of funding that you may want to consider. So if we were talking about a chronic pain clinic, a video group clinic, so you put that in the name. You've got the awarding body. Let's say it's from leftover ARS funding, okay, because that's a common
very credible. There's
so
often that line.
Bear in mind, we're heading into year end. This is going to be a process I think many people are about to go through in the next few months. So requested. So it's likely to be non-recurrent funding. Let's go for a premise. Idea that they put out a call for a maximum of £100,000, for example, because there's leftover funding for that particular networks and stuff that you can put bids of up to £100,000.
Generally non-recurrent, isn't it?
It is non-recurrent, so
that's a constraint on this particular exercise.
Yeah, potentially. So let's say we're putting a bid in for. We'll figure out the amount in a second. We created that today. Bids. Well, it's me and Andy. Elevator pitch. So let's go for something like to create a video group chronic pain clinic to support patients to manage their chronic pain, both in terms of understanding the challenges they face, as well as medication options, healthcare options, and lifestyle changes, supported through a video group consultation method. Okay,
that sounds good. That sounds like it might be about 100 words, I guess.
Yeah.
And also, what you can do is having gone through the later thought processes of, so you might identify as you're going through the thinking around strategic goals that actually a lot of work hours are lost to chronic pain. That a lot of GP and physio and other people's time is spent handling chronic pain, but maybe not being that effective. So you can maybe allude to a few of these things, in your longer sort of pitch as well, to help kind of establish that need and start to link everything together, I guess. So carry on, Gandhi. So where does this fit in with local, regional, or national strategic aims, would you say?
Okay, so let's have a think about this. So bearing in mind, Andy asked me to come up with this just before we started recording. We'll do
it together.
All right, so NHS England priorities in terms of things that can help general practice. So video group consultations has definitely been seen as a method to try and support general practice in terms of its outcomes and stuff. If we're thinking about the clinical aspects, so reduction in opiate use, we know is a constant challenge in terms of, we know that opiates are a really bad way to manage chronic pain, and actually by supporting patients to understand their medications and their other healthcare options far more effective. If we're looking at improving quality of life, so things like health core 20+5, we know that chronic pain is a common challenge facing particularly deprived populations and stuff. So for me and you in our local populations, this is something that would have potentially high use case, impact on ability to work, impact on ability to look after families, preventing social care challenges and stuff that come with that and stuff. And obviously the mental health aspect of, all those kind of patients that will be part and parcel of their chronic journey. I guess the other aspects then is also about, how can this also be aligned to those patients with complex health needs that are high users of the system? Can this be a method of supporting them with their healthcare journey to understand their healthcare needs more effectively and therefore actually have less of the acute use in terms of their chronic pain problems and understanding how to manage acute on chronic flares of pain?
Yeah. I think you did a very good job, Gandhi. I'll just add emphasis to allowing these patients to make more efficient use of healthcare, and will allude to providing them with continuity through attending, this program that we're providing for them, and improving access by reducing the use of acute appointments in general practice and A&E inappropriately is perhaps not the right word, but by this group of people whose needs can be better catered for elsewhere. So I think we're showing that
and I guess just to add in, Andy, this would definitely fit in with the anticipatory care DES that is due to start on the 1st of April. So in terms of future or guidance and stuff that's due to come through, actually this massively aligns potentially to that particular cohort of patients and stuff.
So I guess people are saying that we can actually link this can be linked to specific objectives within specific documents and start to show that this will help the awarding organization meet their strategic obligations as well. So yeah, good. So I think we can do a good job justifying this within the strategic fit.
So for this chronic video group clinic, let's put myself and Andy's name down as leads. And,
okay, yeah, we'll lead it.
Yeah, and I think, in terms of who's delivering it, well, actually, this will be delivered by the practice and PCN staff, but actually in a collaboration with our local chronic pain community clinic, because actually they've got some of this, there's subject matter experts on that particular area. And not to forget that actually, the populations need to be included in this. So actually, there'll be parties in terms of co-production and understanding this kind of process. We may need to approach other groups for advice in terms of how to deliver this, and I'll come to that in a second. But yeah, I think that's the starting point in terms of who's
maybe have a box. I'm just thinking about the tool. Maybe have a box explicitly for partner organisations, just to invite people to think about the idea of partnering. How does this bid improve outcomes for the population? I think we've already started to allude to that. Really, people should have a better experience of their life through lower experience of chronic pain, allowing them to return to work, be more effective in their caring roles as parents or carers for other people, and have better life enjoyment, reduced use of acute services in general practice and the emergency department. So I think we can speak to those things. How does this tackle health inequalities? So I think often you can make the link, in the initial bid and then allude to it later, or speak to it more explicitly later, to say that this is a problem that disproportionately manifests in areas of low socioeconomic achievement. So you can link the problem to inequalities. And it might be that some projects people are doing are more targeted. So people might be targeting, homeless groups or particular demographic groups that are shown to have health inequality in terms of their outcomes. So this is where you can kind of link those things explicitly in there. So it's a good section. How does the bid enhance productivity and value for money? Sorry, Gandhi, you're going to come in on one of the points there.
Now I was just going to come on this next section. So productivity and value for money. So, in terms of, by providing it as a group consultation method, you potentially can have the opportunity to see multiple patients at the same time, while still also tailoring that to their individual healthcare needs by the model of group consultations. And the benefit of offering through a video group consultation route is the fact that you are then supporting potentially not only those patients, but you have recorded content with consent, as long as you have it, to support patients or increase the accessibility at the very least. So, we're talking about patients that have chronic pain that may impact their mobility. That may mean they can't physically come to a particular location, and actually by engaging through a video route, that means that then they have more accessibility to those kind of services and stuff. So, in terms of saved patient time, saved time in services, more effective use of outpatient services and less DNAs, for example, in terms of community-based clinics or secondary care-based clinics, there are potential significant gains you can have through this potential route. And the other benefit, I guess, of a group consultation, as long as one patient turns up, you've still got some use out of it. It may not be as much as you're hoping for, but all you need is one patient to turn up and you've still had some impact. Whereas if it's individual patient clinics, each time one patient doesn't turn up, that's a complete missed opportunity. So you've potentially still got the gains from there.
Yeah, and Gandhi, I would say here, I think even though both of us are not health economists, I think if we were putting this bid together, we could make a stab at doing a financial model that is illustrative to show the benefits of operating in a group and reducing the need for acute consultations, maybe even drawing on some data that we might be able to find from our own systems or more generally about the patterns of usage for chronic pain. So we could probably, make a good go of creating a financial model to justify this intervention as well. And other people can tidy it up later, and we'll say it's illustrative, so people hopefully won't hold us to specific figures.
Okay. Next up, we're then talking about the broader social impacts and socioeconomic impacts. So we talked partly towards this in terms of opening accessibility to healthcare to particular patients who may have challenges accessing it and stuff. Hopefully this will then help in terms of their quality of life, that can have an impact potentially on the services that those patients use, maybe even looking at returning to work or more other options along that lines, which would obviously have a socioeconomic benefit and things, and also to the quality of life of the people around that actual individual. We know that patients where the households have challenges with mental health and chronic pain and stuff are more likely to also impact other members within the household and stuff. So actually there's a byproduct by trying to support those individuals that you have an impact on the others within the household itself.
No, very good. Yep. It's all. I'm sold already.
Fair enough. So what are the risks in management? Well, clearly you have the risk that nobody turns up. I guess that's one issue, but we can mitigate those risks, and we're going to talk about that in terms of the cost delivery and stuff. In terms of the risk of not doing this, well, it's an ongoing challenge that continues to have an impact on service delivery in terms of service use and that kind of stuff. And actually,
missed opportunity, isn't it?
It's a missed opportunity. I think.
We're missing out on the savings. And who would want to risk? Who would want to risk that? I suppose it's a fairly sort of low risk, isn't it, what we're describing? And I guess somewhere we can say, actually, this is a model which, has been used elsewhere and has been successful elsewhere and has a track record. So actually using tried and trusted model will help reduce the risk here as well. So, yeah, I mean, other projects might have sort of bigger risks. Obviously, the engagement of staff and practices and things can be a risk. So you might want to, that it's not recurrent might be a risk as well. People might really, really like it, but we might need to, but there's the winding down risk, isn't there? That might occur if we start to employ people. But we can think of some mitigations and how to reduce those risks within how we design the system. So anticipated time to implement.
We're talking about potentially using ARS funding. So actually one of those opportunities is that if this is successful in the kind of pilot year, that actually there is lines of the ARS funding to support the ongoing use of it and stuff. So actually, that may help. Yeah. And then we talked about system changes that could benefit or hinder this. So I mentioned again, ARS funding is there. So actually, could this be rolled into the network's existing ARS funding to continue the service? Hindrance, actually, we don't know the future of networks post 2024, apart from the fact the ARS funding is due to continue. So actually, is that a hindrance potentially, possibly, etc. and stuff. Then let's look at the costings itself. So because this is obviously the part that I think then is a bit more structured, but also challenging to look at. So, staff costs, if we're talking about using underspends of ARS funding, this is the main reason for the funding existing. So, it's the staff. Is it going to cost a lot of money? Well, not really, I don't think. I think what you would really want to have is a digital care coordinator. somebody to support the patient engagement with the online platforms and the video consultation routes. And a care coordinator role could be really exemplary at helping with that aspects of coordinating the patients to engage with the services, troubleshooting the challenges they may have in terms of onboarding with a video platform or attending and that kind of stuff. Potentially having something like a health wellbeing coach involved from the staffing perspective.
You've highlighted a technology risk, and worsening health inequalities, and there's a whole, just going back to the risk section there, but that's really good things that are just coming out.
But then at the same time, mitigation is having the specific individual whose role it is to help engage those patients with those platforms themselves. And obviously they would hopefully then have the developed skills and understanding of how to support those patients and stuff. Because it is possible. It just takes time. And that's what we're buying here, isn't it? We're buying time.
I'm just thinking here, Gandhi, I guess in terms of the scale of, the staffing that we're asking for, I guess earlier we can have made an assessment of the scale of the problem. How many patients with chronic pain do we have in our theoretical primary care network, and what proportion do we think might be appropriate for this sort of approach, and that might inform the number of hours that we want to run of this per week. And it might be that we think in that way and say we want to run 2 90-minute sessions per week, or alternate weeks, average one a week. We just have to think about the scale in terms of what that'll help inform these costs, won't it? So are we going to have a care coordinator working half of their time on it, and a clinician working half of their time on it? Because there's some development work as well, isn't there, to develop this, because it doesn't just come out of the box working. So actually there's project management time, but we've got to develop the offer as well. So we have to account for that too. So I don't know, maybe that's the amount, include the on costs in there. Estates, we need a room, I guess, in a suitable environment. It might not need to be a GP surgery. It might even be people's homes, because this is delivered remotely, isn't it? And that's how we save costs. And that's some of the attraction of this project. So we can acknowledge that in the estates section. I guess. And
similarly with equipment as well. So you are going to need some video-based equipment. You're going to need the platforms to run it off, whether that's Teams or other kind of platforms and stuff. Are you going to need some onboarding support in terms of showing patients how to do that? So time, like you said, the project management time, do you have to create, for example, a guide for patients of how to onboard themselves, or is it even more structured in terms of having somebody specifically go around to the particular patients and show them how to use the system in the first instance before the actual session, so then they know how to do it and things? So it's thinking about those opportunities and things that come into play. Project management, we've talked about, you need some costings of actually the fact this is going to cost a little bit of money to get started. Where's that funding coming from? Is that from the Rs fund, the Rs underspend pot, or is it actually you may need to consider adding some additional funding into this to support it, from existing pots that you already have? And then obviously there may be ancillary costs that come with this in terms of outcomes, reports, that kind of stuff as well that need to happen.
Oh, and Gandhi, let's add some training costs in, to the staffing, because I think we might need to train people both on the technology and both on group consultation approaches to chronic pain. So we might want to find a course for them to do, and include that in the costings as well. Just an example of to consider, that training requirement, and maybe there's an engagement need with practices or those people that we would want to refer people into the service to make sure that we have enough referrals in. Say maybe we want to do some sessions with the surgeries. I'm not quite sure what that would look like at this stage in planning, but we can put a cost line in for it, I guess.
And then hopefully that will give you an amount that you can then put into the bid right here at the top.
So Gandhi, I have quite a lot of confidence in this bid that you've put together. It feels really, really well structured and well thought out. But I think that's because you've applied some logic and you've gone through a template. I can really see how this would be useful for an individual or a group of individuals to kind of just quickly flesh out an idea. And also by the end of it, you might have a sense of whether it's actually got legs or not, as a project, and you might actually find a lot of flaws in what you're proposing, or that it's just going to be ridiculously expensive in terms of the impact. So I think that's a really good tool that we've walked through there, and hopefully it will be useful for people as they keep their bids warm in the background, ready for pots to become available at short notice, and maybe even some ARS underspend in the near future.
And if people do want to access that particular tool, the link to it is down below in the description of the show notes of this particular episode and stuff. So you can go and access it easily, effectively. And yeah, hopefully you'll find that useful. If you've got parts that you think we could adapt, let us know. Happy to add in, we may be adding some extra columns in there already, just as we've kind of gone through that again, in terms of actually parts that may be more useful to add in and stuff. And, hopefully that will be a tool that you find really effective and useful, particularly as we come into bidding season, because it is, isn't it? Coming up to March, it's the season for putting your bids in.
People need to get the money off their books and spent, I guess, as often happens both in the NHS and everywhere. Cool. So hopefully people have enjoyed that episode and found it useful. And we'll see people again in the future with hopefully lots of useful content.
Let us know if you have found it useful. Comments down below, very much appreciated. If you found this particular content effective, do subscribe and like the video and share it actually with other people that you think may need to know how to do this more effectively, or even better yet, share it with your colleagues before you actually have the meeting where you're going to talk about doing this within your practice, within your network or wider area. And as always, we'll join you to tech enhance our primary care and learning in the next episode. See you later.